All right, I see that it's 12:01 and folks are getting online, so we'll go ahead and get started.
Okay.
Um, my name's Celia Herring. I'm one of the UW Montlake inpatient chief medical residents. I want to welcome everybody here today to today's Department of Medicine Grand Rounds and remind everybody in attendance that you can submit any questions you might have throughout the course of the talk by the chat function. I'll monitor those questions and make sure that we get to ask as many of them of Dr. Kimmel at the end as possible. For today's grand rounds, we'll be hearing from Dr. Ryan Kimmel, who's a professor and chief of psychiatry here at University of Washington and the director of the Psychiatric Consultation and Telepsychiatry program. And as you can see, Dr. Kimmel will be presenting an update on bipolar depression and a framework to understand the current antipsychotic spectrum. And with that, I'll hand it over to you, Dr. Kimmel.
Thanks very much. I appreciate the opportunity to talk to you. I pitched two different ideas about what folks might like to hear about, since there's a giant new building going up on the Northwest campus that has 50 medicine beds, and even the psych beds have a purpose that will impact folks from a variety of different subspecialties. But and I also, or a clinical update was some other option, and the answer was both. So there's not an easy segue between these two, but I wanted to give you a little bit of a clinical update on something important, and then I won't belabor it too much. So if you're bored with it, then the update on some more health systems, things like that, will come after that, and I'll keep that focused. I have to show this with language from the CME office, which is why it looks like I'm referring to myself in third person, but I don't have any financial disclosure. So the reason I want to talk, trying to think if I could give one update to providers not in psychiatry about something that has changed dramatically since your residency, since your training, it would probably be about bipolar depression, because this is one of the few places where the top line of the treatment algorithm, that is the first line medication, the right answer to that question has changed. Whereas, with major depressive disorder and panic disorder and generalized anxiety disorder and OCD, things like that, the first line of the treatment algorithm is still an SSRI. And with schizophrenia is still an antipsychotic. However, bipolar depression, how we think about treating this, even how we kind of conceptualize what it is, has changed 2 or 3 times since I started residency in 2001. And so I wanted to talk a little bit about it. The other reason why it's come up a lot is because the Department of Psychiatry operates a statewide consultation line wherein any prescriber in the state can call and reach a psychiatrist 24 hours a day, every day of the year, to talk about difficult cases. And half of the counties in Washington state don't have a single psychiatrist. And so a lot of primary care doctors and hospitalists call and are asking us questions about bipolar depression for the same reason that it looks like the recommendations have dramatically changed since they did their training. So I'll just talk about this a little bit, and not only talk about what's indicated, what's FDA approved, but also how to pick between the medications if you in a pinch if you need to, and how we make that clinical decision. The key point is, so when I started residency in 2001, if a patient had bipolar disorder and was currently depressed, what we were told to do was put the patient on a mood stabilizer like lithium or Depakote and add Wellbutrin, because it was felt to maybe be less likely to induce mania. Turns out that antidepressants don't consistently show benefit for the depressed phase of bipolar disorder. There's lots of studies on it, and there's lots of meta-analyses, some of which show no benefit, some which show maybe a tiny benefit, barely, in terms of the confidence interval. But this isn't it's the first really important one, which was in the New England Journal of Medicine about a year or two after I got out of residency, that compared treatment responses. All the patients were on a mood stabilizer, and half of them were on a placebo, that's the yellow. Half were getting an antidepressant, either Wellbutrin, bupropion, or paroxetine, which is Paxil, an SSRI, and bupropion, which is a different mechanism. It didn't work. Wasn't even trending in the right direction in terms of remission of their depression, transient remission, where just the patient gets better for a bit and then either gets manic or depressed, or even if we hedge and call it like a treatment response with an improvement of symptoms, regardless of how we tried to look at it. Antidepressants didn't help. And so this led us to rethink this issue of bipolar depression. It could be that bipolar depression and major depressive disorder, that the depressive episodes in each have similar symptoms, but completely different biologic underpinnings. So this happens a lot, of course, in medicine, where it's a common set of symptoms, but there's a broad differential, and the treatment for one of the items on the differential is much different than the treatment for the other things. There's some other evidence that bipolar disorder and major depression may be very different. They don't overlap all that much genetically in terms of family genetic studies trying to identify genetic regions, whereas bipolar disorder and schizophrenia, for example, overlap much more frequently than does bipolar disorder and major depression. And there's this evidence that the medications that seem to work for bipolar depression as single agents don't seem to work as single agents for major depressive disorder and vice versa. So that's why I wanted to talk to you about it. There's a couple more reasons, actually. The other reason is in bipolar disorder, it's way more common for the patient to be depressed than manic. This was a 10-year kind of naturalistic, the patients could have been treated or not treated, kind of study done by the NIMH. And so patients with bipolar 2, that's on the right, they spend half the year, 50% of the year, in a depressed phase. And only 1% of the year, so whatever that 1.4%, whatever that is, 4 days of the year in a hypomanic state. The burden is much more on the depressed side. And of course, there's an increased risk of suicide and depression. Similarly, in bipolar 1, even though the mania is bright and attention grabbing, and sometimes leads to hospitalization and lots of regrettable decisions, so does the depression. The depression is much more common, even in bipolar disorder type 1, than is mania. And yet, we are not nearly as good at treating bipolar depression. Maybe this partially reflects it. We're not nearly as good as treating bipolar depression as we are in mania. And evidence of that is the medication. So this is a busy slide, but it's busy with a purpose. It's busier on the left than the right. On the left are all the current medications with some type of FDA indication for bipolar disorder in various phases. There's FDA indications for acute mania or mixed states. Mixed states are where the patients have simultaneous manic and depressive symptoms. Bipolar maintenance, which is a way of evaluating whether versus placebo, the patient is less likely to get manic or depressed. They're less likely to have any kind of positive or negative mood episode. And then acute bipolar depression, where the patient arrives to your office depressed, and a medication that can improve that depression. So that second column, I guess, with the years, that's the year that it was FDA approved. Lots and lots of things work for mania. We're pretty good at treating mania. Fewer things work for maintenance. That's a challenge. It's complicated because it's harder to do those studies, whereas you can put out the fire of a mania over the course of a week or two. Bipolar maintenance studies are longer, more complicated, more expensive studies. And so if a drug company is going to seek that indication, it just requires a different kind of effort. But there is this issue with there aren't as many medications for bipolar depression. And it's independent even of whether or not the drug company is designing, is going after the indication. There are lots of antipsychotics that do not show efficacy for acute bipolar depression. And we don't really understand why some seem to work and some do not. A confounder, there are lots of confounders. Well, a challenge, I should say, in identifying why biologically, pharmacologically, why some work and some don't, is that all these antipsychotics bind many different receptors in many different degrees and combinations. And moreover, a lot of them have active metabolites. And so it could be that some of these that work for bipolar depression is not so much the parent compound, but the active metabolite. But there does seem to be this narrow subset where they consistently beat placebo and have an FDA indication, unlike antidepressants. All of them are antipsychotics, interestingly. There are 5 in that far right row. The only one I'm not going to talk about, it's complicated, is that olanzapine fluoxetine combo pill. It's called Symbyax. I've never seen it used. And it's a long story whereby it got an FDA indication. I'm suspicious that it's the olanzapine and not the fluoxetine that was conveying efficacy, but it's hard to know. But regardless, I've never seen it in the wild used. And so instead, I'm going to talk about the four that you will see used and how the difference between them, it'll teach us a little bit about antipsychotic medications in general, and also why we choose sometimes one over the other and why some things are at the top of the treatment algorithm and why some are not. So those four, just so you know, so I guess in order, ignoring Symbyax, in order that they came around. So Quetiapine, the original was 2004 and the XR version came around in 2008. And then there was a big gap. That's important. I'll come back to that in terms of the volume of data that we have. And then lurasidone, which was called Latuda, is now generic. And then most recently, cariprazine, which is called Vraylar, and lumateperone, which is the most recent one that you will see advertised to patients and to you on TV. It's another reason why I wanted to talk about these things, since the patients will come in asking about it, and depending on whether or not the TV show thinks that you're part of the target audience, you'll see it seemingly advertised to you as well. So those four are what I'll talk about. So first of all, the net price, Quetiapine and lurasidone are generic. You can get them for cheap. Quetiapine is very cheap. Lurasidone is about $30. Some of that might be, the kind of game that's played with offering a coupon. It might be more like $150 or $160 if you had to pay for it purely with cash. But cariprazine and lumateperone are not generic. And there's a significant difference in the monthly cost. When new antipsychotics come out, whether or not it's for bipolar depression or schizophrenia or whatever, this is about the monthly cost. It's extraordinary. Patients would not be able to pay for it. Moreover, you can see why insurance companies would balk if you're trying to prescribe it and haven't demonstrated that the patient has failed some other things. So part of what I'll do too is come back to try and articulate whether or not the expensive ones actually work better, whether there's value in the price. But I'll talk about these things a little bit in terms of the evidence, and then other ways that we can compare them. So 2 hours and hours on Quetiapine because it's been out the longest, and we have studies that aren't sponsored by pharmaceutical companies. It's hard to find a study for bipolar depression where Quetiapine didn't beat placebo. If you're taking one medication to a desert island and all you really cared about was efficacy, we just have the most evidence for Quetiapine. These were some of the original ones. They illustrate a couple points, themes that will run through the talk. And so I'll highlight this one for a second. They chose 2 treatment arms, one at 300 milligrams, one at 600 milligrams. The FDA max for Quetiapine is 800. And so they kind of just chose 2 that were in the middle. 600 is a little more like we use for significant schizophrenia. 300 is a bit on the low end for that. And I think they just kind of chose 2 arms that were different from each other. I made lithium yellow, and this seemed appropriate, and placebo green. Both the 300 and 600 arms of Quetiapine beat placebo statistically. Lithium was it was in the middle. So much in the middle, was neither statistically significantly worse than Quetiapine nor better than placebo. I'll come back to that. The first thing that's interesting though is this placebo arm. If you look at it, there's a 50% remission rate. It's a big challenge to do bipolar depression research because it's an episodic mood disorder. So if you need a 28-day washout because the patient's on Prozac and it has a 7-day half-life or whatever, between identifying patients, washing out the other medications, rolling them in the study, and titrating medications, pretty soon enough time has passed that some of the patients have had their depression resolve spontaneously. That's not to say that they won't go on to another depressive episode down the road or mania, but the placebo response rate is pretty astounding. And so while the treatment medications do beat it, you can see it can be hard to do these studies. The other thing, this idea of lithium level is a challenge. We often think of blood levels for lithium as therapeutic between 0.6 and 1.0. The further you get over 1.0 or 1.2, the more likely you are to have side effects. We don't know very well, however, if that window is flat, I guess. That is, whether in terms of efficacy, 1.0 works better than 0.6 in terms of bipolar depression. We just have this data for maintenance. And so it's kind of a low lithium level there. We could think about that a little bit. Okay. I don't want to deliver kind of encyclopedic information, but these things track along in similar ways. So lurasidone is the other one that's generic. I'll compare them in other ways. I always remind folks that it has to be taken with a 350 calorie meal for absorption reasons, not because it has GI side effects that are mitigated if you take it with food. It doesn't get absorbed very well. And so I've had lots of patients who on the inpatient psych unit who hadn't realized this. And all we have to come in on lurasidone, and all we have to do is start giving it with dinner, and their symptoms improve. We don't have to mess with the dose. But it's an important feature. Ziprasidone, which is Geodon, a medication for mania and for schizophrenia, is similar in that it has to be taken with food. Also similar is this idea that whereas in schizophrenia, we tend to use it at these higher doses, like 80 to 120 milligrams a day, just like quetiapine, you can use it at a lower dose and it has efficacy for bipolar depression. Moreover, the number needed to treat actually increases at the higher doses, meaning you get more of a dropout because of side effects at the higher doses. And so like quetiapine, you can use it at lower doses. I'll come back to it, but it's important to know about this medication because it's the other one that's generic with an FDA indication. Okay, cariprazine, Vraylar. Vraylar is a terrible name if you want a placebo response. It's a partial agonist that functions as an antagonist in the presence of a full agonist, as partial agonists do. It's more recent, and so the studies are a little more nuanced, which I appreciate. They're thinking about some of the studies include patients that have both manic symptoms and patients who have, along with their depression, or have pure depression. It's effective at doses that are not its highest dose. In fact, just like Latuda or anything else, you increase the side effect profile, more patients drop out, and with such a thin margin between, with such a high placebo response rate, anything that disrupts the dropout rate with the active treatment disrupts the findings in terms of significance. I put some papers down there. If you're just going to read one, those are things that you could look at that are kind of more clinically focused advice for providers. But those are two of the medications. The most recent one, the one that I keep seeing advertised, is Caplyta, lumateperone. I want to talk about this because it happens in psychiatry a lot. Might happen in other classes of medications as well. It's just that I tend to follow the psychopharm literature. Everything wants to advertise itself as first in class, as if first in class is synonymous with higher efficacy or fewer side effects. And so I've been around long enough now that I've seen a lot of medications in psychopharm that advertise themselves as first in class, and it doesn't always mean much, but it's an effective way to advertise, that's for sure. The other way that's an effective way to advertise, same idea, is biologic plausibility. That is a receptor or a combination of receptors that a medication interacts with that makes it different than other medications. Think as prescribers, we like biologic plausibility, even if we don't know enough about the receptor system or the projections in the brain or anything like that to really debate the biologic plausibility. That a biologic plausibility is advertised is an effective way to get prescribers to try something. So like all antipsychotics, Lumateperone binds to the D2 receptor and a very specific serotonin receptor. I should say, like all second generation antipsychotics, everything from that started with clozaril in the late 70s and moving forward through risperidone, olanzapine, and Seroquel, and all the other things. A difference with this medication, it binds to a specific glutamate receptor. Lots of work is being done in psychiatry on glutamate receptors. The jaded side of me says, does the glutamate receptor actually impact efficacy, or does it just cause sedation? I'm going to show you some evidence. These things do work out sometimes. It might be important, but this is a very recently released, very expensive medication, and I'll show you some of the efficacy data. It has approval for, by the way, for schizophrenia, for bipolar 2 and bipolar 1 and bipolar 2. Another thing it does quite effectively in terms of an advertising strategy is advertise itself as effective for bipolar 2 depression. And it'll say it's the only one that's approved for bipolar 2 depression. That's technically true. Implied in that claim is that there's a difference between bipolar 1 depression and bipolar 2 depression. There's some evidence that that might be true. There's some evidence that that might not be true in terms of the phenomenology of bipolar disorder. But even though we've had this diagnosis of bipolar 2 is actually coined by a UW psychiatrist named David Dunner in the late 1970s. Even though that idea of bipolar 2 has been around now for 4 decades, we still don't quite understand the difference between those two. But in terms of the idea of creating personalized medicine, or on the prescriber side, saying, here's a medication that's not just for bipolar disorder, but is for bipolar 2 depression, specifically for the patient that you might be seeing in front of you. And maybe there'll be something to it. I just don't know yet. A lot of the other medications that are FDA approved for bipolar depression, it was before the studies were separating bipolar 1 and bipolar 2. They might have worked just as well for bipolar 2 as bipolar 1, or maybe not. We just don't know, because like in that Quetiapine study I showed you, the patients could have bipolar 2 or bipolar 1 depression. We didn't separate them out previously. And if you're looking for an article to read, there's a good one from the American Journal of Psychiatry by an author who's good, highlighting a randomized control trial. What's interesting, however, as I talk about this issue of me being skeptical, or at least needing a little more time to be convinced that something that's new is always better, there's the remission rate at day 43. The MADRS is a rating scale. So the medication beat placebo by 6.4%. That's not outrageously different from that Quetiapine study I showed you, where the response rate was 50%. There, it's maybe 11 or 12% more, 10% more. But this isn't dramatically different. And if you kind of calculate the number needed to treat, 6 goes into 116 times. It's not like this is a dramatic game changer necessarily in these initial studies. I'm not saying it's not efficacious. It's not necessarily miraculous in terms of efficacy. Okay. In trying to update you a little bit about antipsychotics in general in a way that's clinically useful, this is one way to look at the spectrum in terms of one of the significant side effects. So there are lots of potential side effects of antipsychotics. The two big ones are dopamine blockade mediated side effects like Parkinson's, tardive dyskinesia, akathisia, hyperprolactinemia, those things. Another one is the metabolic syndrome that's associated with atypical antipsychotics. This would be weight gain, new onset diabetes, hyperlipidemia, increased abdominal circumference. You can line these medications up by their antihistamine effect. So this is where I give you traumatic flashbacks to undergraduate biochem and talk about the dissociation constant. That's that Ki. This is good. This is exposure therapy for your undergraduate biochem trauma. The lower the dissociation constant, the lower the Ki, the more tightly the medication binds to the receptor. And the scale is logarithmic. even though I have them lined up linearly here. So clozaril is the strongest antihistamine, followed by olanzapine and then quetiapine and cariprazine. I put these ones in yellow, 3 of the 4 that I'm talking about in terms of bipolar depression, but all these other ones as well that you will see used. Brexpiprazole is called Rexulti, risperidone, Abilify, which is aripiprazole, down to ziprasidone and lurasidone. These things track. So if all you can remember clinically is if you have a sense of which antipsychotics cause people to get sleepy, which I bet you do, because you know that quetiapine is sometimes used in the hospital for insomnia, even though I don't love it as an insomnia medication outside the hospital. Or we use olanzapine in the emergency room, or in agitated delirium sometimes, in part because it's sedating. The medications that make patients sleepier are more associated with a metabolic syndrome. And it's not because the patients are too sleepy to get off the couch and exercise. There's something independent about binding this histamine receptor that causes metabolic side effects. It'd be interesting to know, actually, if patients who took Benadryl every evening for sleep or allergies, if they gained weight. Anyway, they line up this way. And so that's the take home that is helpful, is if the patient's complaining of metabolic side effects, you see the metabolic side effects, switch to a medication that's less sedating. And antipsychotics less sedating, and that's true for if you're augmenting for schizophrenia or bipolar disorder, or some of these antipsychotics have data for refractory depression or OCD. Okay. Oh, lumateperone. It throws off my grand theory of everything. The slide was beautiful until lumateperone came out. And then I have to add this little pop-up at the bottom. It doesn't bind the H1 receptor. It does not have any histamine effects, except 24% of the patients experience sedation, probably from that glutamate receptor that I talked about, or something else. But that's why I was suspicious about whether it actually conveys increased efficacy, because it's not that much more efficacious than the other antipsychotics that are approved for bipolar depression, or whether or not it just causes sleepiness, as you might expect some glutamate function to do. Okay, this is a way to compare the 4 in terms of side effects. I should have said in terms of efficacy that no head-to-head trial has been done. And in meta-analyses, at least the ones that have been done, no one of these 4 separates from the other 3 in terms of efficacy. And we don't have any head-to-head trials. So we're really choosing by price and side effect profile. This data is from the package inserts, so the trials whereby the medications got FDA approval. And I lined up these 2 principal side effect things that we think about with antipsychotics: the metabolic side effects, new elevated glucose, new elevated LDL after starting the medications. There's this metric that the FDA tends to use, weight gain that exceeds 7% of your body weight. I don't know why they chose 7%. Might have been a negotiation that resulted in a compromise where they said, we'll call it 7%. Though I do think, if you quick do the math about what 7% of your own body weight is, I feel like if I gain 7% of my body weight, it would take an effort to lose it. There's some value in it, in thinking about it that way. And then these other markers, side effects of antipsychotics in term with the D2 blockade. So, Parkinson's disease, issue with the lack of dopamine, substantia nigra, Parkinsonism, or side effects caused by blocking dopamine receptors in those same pathways. Akathisia is a side effect wherein patients feel like they have to squirm. They can have to move. It's really uncomfortable for patients. You see pacing or squirming. It's an uncomfortable experience for them. So quetiapine has almost, I could have showed you a table of D2 dissociation constants and lined them up as well. So I worried I would lose you. The quetiapine is a very weak antagonist of D2. And so it has a very low rate of Parkinson's and akathisia, and also a very low rate of tardive dyskinesia from long-term exposure. Those are involuntary movements from long-term exposure to D2 antagonists. I mentioned to add plausibility. So if we go from the top here in my grand theory of everything slide, quetiapine should have more metabolic side effects than cariprazine, and they should both have more than lurasidone. And that's what you see in those first two columns. This quetiapine does seem to have a higher rate of metabolic side effects. And it's, on the weight gain side, it's about even with cariprazine, which is kind of where it was in terms of its H1 binding. The hard part is that these are short-term studies. If it could be an 8-week study that could demonstrate efficacy in bipolar depression, that depression might improve over the course of 8 weeks. So that would be long enough to demonstrate efficacy. It may not be long enough to fully elucidate the side effects. That's what we have. It's a challenge. The cariprazine and lurasidone especially, those two have a more of an antagonistic effect on the D2 receptor, which is why they have higher rates of Parkinson's and akathisia. So clinically, we're comparing the two generic ones, quetiapine and lurasidone. You start the patient on quetiapine, it's making them too sedated, or they're starting to have more weight gain, or starting to have these metabolic side effects. You could switch them to Latuda, and they're much less likely to have those side effects, except then they're more likely to have the D2 side effects. There's not a perfect medication here, or vice versa. If you had a patient where they already had some of these issues, diabetes, obesity, and you said, okay, well, I want to minimize that the risk of that. We'll hope for the best and use Latuda, lurasidone. You can. The challenge is there'll be a slightly higher risk of these other symptoms that might necessitate going back and trying the quetiapine, depending on how impactful those side effects are. The new one, somatoform, advertised itself as could be kind of incredibly weight neutral. But I found there's a trial that isn't randomized controlled, but at least it's longer, for a year, even though this medication hasn't been out very long, which articulates some risk of glucose, new diabetes or a new hyperlipidemia. Of course, we don't know either because it's not controlled. We don't know what else the patient was taking. Some of that is because of other factors. We can't control for anything. Interesting, in those patients, though, they do seem to lose a little bit of weight over the course of a year. That would be something interesting. It's a small amount of weight, but it's definitely not weight gain. And again, we don't know about other factors, but that part is interesting. But that's kind of a way to make a clinical decision based on these, choosing between these kinds of things. Okay, the last thing I want to talk about, I feel like every psychopharm, maybe every pharmacology or every medicine, our field, talk should have a little bit where we highlight the biases that come into play with diagnosing and prescribing. I feel like psychiatry is particularly at risk of this because, let's say, if we're treating bacteremia, you can get a blood culture, you can see what it grows out, you can test the sensitivities of various antibiotics. There's some empirical evidence around the diagnosis and the treatment choices. Whereas I don't have a blood test or a genetic test or an MRI or anything to make these diagnoses. None of us do. And so it introduces the potential for bias. I grabbed this handout. I think I grabbed it at the APA meeting. The drug rep was probably delighted that I took it, not realizing that I was going to use it as a cautionary tale. It's a white woman whose face is here. In our country, women are diagnosed with bipolar disorder 2. That's this medication is advertising itself as the first bipolar 2 medication. Women are diagnosed with bipolar 2 far more often than men are. And this is dubious as to whether there's actually evidence of this. I can tell you there's nothing protective on the Y chromosome for bipolar disorder. But as a field, we tend to overdiagnose young women for lots of different reasons that you can imagine. We could do a whole hour on gender biases in terms of diagnosis and prescribing in behavioral health or in medicine. We're more likely to have been the victim of sexual violence or ongoing domestic violence that could result in episodes of depression. The way that providers interpret expressions of emotion can vary. So a variety of factors leads to this idea that maybe we're overdiagnosing women with bipolar disorder type 2. And I think these things tend to compound themselves. Like, I wonder if the makers, I don't know this, the makers of Lamanopron, if they thought things like, when a prescriber closes their eyes and thinks of a patient with bipolar 2, is this the patient they would see first? It's important to think about these things. And then what's reinforced in terms of advertising. And you'll see this in the TV advertisements directed at you and patients as well. And so I just want to think about these things. It's an immense problem, especially in this era of electronic health records where diagnoses get carried forward for decades. These are not innocent medications. They're antipsychotics. And so thinking about bias in this, I think, is something important just to highlight for a minute. And we see this, of course, in other parts of medicine too, with studies of gender or racial biases in terms of our prescribing practices. So I wanted to just mention it. And it also highlights then this idea where this company is very specifically comparing itself to the other medications I just told you about, the exception of Simbax, which I didn't belabor too much, and advertising itself as for bipolar 2. Quetiapine XR, by the way, went back and pursued this too. Okay. That's what I wanted to talk about in terms of the bipolar piece. I was also asked to give a little bit of an update on this new building and how it'll impact services for a broader group of specialists across the hospital. So I'm going to pivot. Even the slide format changes. For quick background, Washington ranks in the bottom quartile in terms of psych beds per capita in the country. This is compounded because Western State Hospital lost its CMS certification in 2018 and thus hasn't admitted a civilly committed patient since. They still admit forensic patients, but not a civilly committed patient. This has a downstream effect, wherein we already didn't have very many psych beds. Acute psych beds, let's take Harborview, for example. An acute psych unit, meaning you can get admitted right out of the ED or right off the medicine service to that unit, or the adult psych unit up at Northwest as well. They're full of patients who, well, there's some patients, I should say, not full of patients. There are patients there who are have stayed a longer period of time and who would benefit from they don't need forever hospitalization. It just takes a little bit longer due to a variety of circumstances to get the patient stable or stable enough that increases the odds that they won't bounce back into the emergency room. But since there's no unit like that, since Western isn't admitting anymore, those patients pile up on psych units, and then the patients who need acute hospitalizations pile up in the emergency room or board on medicine, as is the case at Northwest currently, or were initially hospitalized on medicine and involuntarily detained, and now they're medically clear, but they spend extra time on the medicine service because there are no psych beds available. So if we can relieve acute psych units of some of these patients who require a slightly longer term stay, then we can open up beds for patients in the emergency room and on medicine. And that's part of the goal of this new building that is, I'll tell you a little bit about. So it's called the Center for Behavioral Health and Learning. There are 100 medicine beds, not 50 medicine beds in it. We'll come back to that in a second. The Washington legislature partnered with UW Medicine and gave $244 million to build this facility. Besides treating a variety of kinds of patients, a lot of it is around workforce development as well. I mentioned half the counties in Washington don't have a single psychiatrist. We also need more psych nurses, social workers who want to do hospital work, all kinds of folks, nurse practitioners, PAs, to get trained in a nice building, good teachers with patients who are ill but get better, and maybe have a better understanding of working with these patients or go into the field in particular. So in this building, there'll be 25 geropsych beds. These are acute beds, not the long-term ones. Patients coming right out of the emergency room or off medicine. It'll be the only geropsych unit, I think, in the state. We have a unit up there, which is predominantly geropsych, but technically also takes patients who are just adults. That'll move into this building. There are going to be 50 med-surg beds where we will proactively co-locate patients who are on medicine, who are hospitalized for a medical reason, but they have behavioral health comorbidities. You can develop unit-specific policies. You can develop skill sets. You can education, all kinds of things for the staff and the patients to better take care of patients who are simultaneously struggling with medical and behavioral health things. That's part of what those 50 beds will be for. There have been a few of those medicine beds that have more of the ligature proof. You can lock up the oxygen and the suction and things like that. There's fewer ligature points around the room as well. They're a little safer for patients who might have suicidal ideation. And then there are 75 psych beds for patients, not acute patients, but patients on these 90 to 180-day involuntary commitments, civil, not forensic. So, there are patients who you need a month to titrate up the Clozaril and give it another month to work for its psychosis. The patients have brittle diabetes to go along with their schizophrenia, and we need to find a medication that doesn't make that worse and, have a good endocrinologist see the patient periodically to say, can we stabilize both things and really give the patient a chance medically and psychiatrically to succeed outside the hospital. We don't have a unit like this, and so it's hard for people to sometimes think about what it is. An analog might be rehab medicine on 8 North, where those patients on rehab medicine at 8 North at Montlake, those patients aren't admitted right out of the emergency room. It's patients who meet a certain criteria are taken off of medicine and surgery or neuro or whatever, who'd benefit from a longer stay in the hospital with specific treatment targets and a specific ability to participate. But it's that kind of idea. Maybe it's the best way to formulate what that unit is. Other things, it's very ECT and TMS are modalities for patients with certain diagnoses that haven't responded well to medications. Transcranial magnetic stimulation doesn't require an anesthesiologist. It doesn't involve a seizure, and is FDA approved for refractory depression and OCD. ECT is not what it was in the movies. It's come a long way, and it's very effective. In fact, much more effective than medications for certain diagnoses. And it's very hard to get either of those things for patients in our community, especially patients on Medicaid and things like that. And so that'll be useful. It also will help get some patients out of the hospital. As I mentioned, those of you might know this too, that a lot of the psych units in our state and in our region are standalone and they aren't attached to a hospital. And so they have a very low tolerance for medical comorbidities. There's an advantage to having a psych unit with access to a group of hospitalists and subspecialists. We designed it during COVID. It's negative pressure rooms, which is helpful. Some of you might remember trying to manage patients who ought to have been on the psych unit. Psych units are a little more like a cruise ship. That is, the care of the patient, a more sophisticated way to say this is, on a psych unit, the care of the patient takes place outside the patient room, in common areas and group therapy. Whereas on medicine, the care of the patient takes place inside the room. Communicable things get transferred easily on psychiatry units. And so and then patients with COVID get stuck on medicine when they're medically cleared and just waiting for the COVID to clear. There's some advantage to some of these things. Dialysis is also an issue. And then some other resources we'll develop. thinking about how to educate and train family and caregivers who will be taking care of patients with serious mental illness at home or in adult family homes or wherever, to better enable the care and the patient kind of success. There's the building. That area with the flag is an outdoor area for patients. I did residency in San Diego where all the psych units have outdoor areas. It seems strange to me that what's the problem? The patients on psychiatry here are stuck inside, especially if you're spending 3 months on psychiatry. You need an outdoor area, and there are outdoor areas actually on every floor. The medicine floors are on the second and third floor, 25 beds each, and there are the neuromodulations on the first floor. The cafeteria for the whole hospital is in this building. I like this idea that we've talked about integrating behavioral health care and medical care in the outpatient setting. They're still pretty siloed off in hospitals, but this is a building that actually have both. There's the outdoor area. There's this big awning, so even if it's a little misty or rainy, that fencing isn't chain link fence because I didn't want it to look forensic. It's up off the ground, so people aren't just staring in. And there are other outdoor areas, these kinds of balconies you can see that also have this screening. You probably would have called them smoking porches 60 years ago in hospitals, but they're little outdoor areas for the geriatric patients and for the other long-term care patients. And these big sunny areas, part of the challenge on psychiatry then is no one's depression gets better stuck in their room. You have to have outdoor areas and in common areas that draw patients out of the room, and then the care takes place in bigger treatment rooms. So most of them are single rooms. We don't make medicine beds that are shared anymore. It's kind of an equity issue. We should have most of the psych beds have private as well, and then they all have their own bathrooms and showers and things like that. So you'll hear more about that. Some of you will rotate in it. Some of you will do consults to these 75 beds. Some of you will have patients who go from your service to these, depending if they're already on a longer term stay, depending on how long they've been in the hospital. But it's something you'll hear more about. So that was the latter half of my presentation, even if there wasn't a good segue. So I'm happy to answer questions.
Awesome. Thanks, Dr. Kimmel. We did get a number of questions that came in throughout the talk, and maybe we'll just go in order, which we'll jump back to the first topic first, if that works for you.
Sure.
The first question that came in is whether there's any progress being made towards a mechanistic understanding of disease pathogenesis, I think referencing bipolar disorders, that can guide the development of new drugs, and
There
sort
are,
of lumped
and
in with that, whether
Oh,
there's a mechanistic explanation for the efficacy of anti-epileptic drugs in depression treatment.
yeah. So one challenge is you're talking to a clinician and not a neuroscientist. I don't do research. Well, that's not true. It's systems research. There are lots of mechanistic research. That's how we arrived at this glutamate idea. And I'm not saying that's not going to be effective. And we see this in other things too. You know, we see this in ketamine's efficacy in depression is not at all based on the same receptors as SSRIs. So yes, there is research. I left a bunch of it out because I thought this group wouldn't be as interested as a psychiatry grand rounds. But there are neuroscience folks doing that research in our system. And it is true on the second half of that question. Psychiatry has stolen a lot of anti-epileptic medications from neurologists. Not all of them have efficacy, however. So Keppra doesn't have efficacy as a mood stabilizer. Gabapentin doesn't have efficacy as a mood stabilizer. Even though some of the other things like Depakote, valproic acid, carbamazepine, lamotrigine, those have efficacy. We don't have a perfect understanding of whether there's a common reason why it would work as an anti-epileptic and a mood stabilizer, or if they're working, its efficacy is the same receptors, but in different parts of the brain that compare it. What else?
Yeah, the next one, I think this is a bit more of a comment, but I'll share it with the group. It looks like it comes from somebody in our audience who works in allergy at Montlake. who notes that in general they recommend H1 antagonists like Zyrtec, Allegra, Claritin, and Friends that are non-drowsy, and they don't typically see any weight or metabolic issues with those, although they're not sure if that's tracked in the literature.
Interesting.
They say, I'm not sure in the literature if the first generation H1 blockers also increase the likelihood, but it's very interesting regarding the sort of sedation metabolic syndrome thing.
Yeah.
And they also note that in their practice, they know that medications like TCAs do have some antihistamine properties, and they therefore recommend stopping these meds prior to skin testing for more valid test results. And
Yeah.
they suggest this might be an interesting topic of research for
Yeah.
trainees or others who might be interested.
Yeah, it's true. One reason why well, there's multiple reasons why tricyclics are a little out of vogue on the psychiatry side. I feel like I see them most often for pain with nortriptyline and things like that. The antihistamine effects and the anticholinergic effects, they just have a lot more side effects. Moreover, they're much more lethal on overdose than SSRIs. That's probably the principal reason why they've fallen out of vogue. It's not for lack of efficacy. They do. You probably see amitriptyline for sleep more often than you see amitriptyline for depression these days.
It looks like the next question was from someone wondering about in the scenario of very severe agitation in folks with dementia and needing some sort of pharmacologic treatment option to manage the
Yeah.
setting of becoming a harm to others despite non-pharmacologic approaches. If you could comment on your use comparing antipsychotics in especially quetiapine, it looks like, and versus
Yeah.
risperidone.
This is a whole other lecture. It's a challenge. For starters, geriatric patients with dementia have demonstrate increased all-cause mortality when taking antipsychotics. Worse, and it's not just cardiovascular, it's usually all-cause mortality. We don't completely understand it. Worse with first-generation antipsychotics like Haldol, Elixir are still around. Less, but still increased mortality with second-generation antipsychotics. However, and the data, it's a very difficult study to do to demonstrate efficacy over placebo. It's one of those issues where sometimes it's all we have, similar to agitation and delirium, where clearly the antipsychotics don't demonstrate efficacy, and that yet we still have to use them sometimes. So we try not to use antipsychotics as a first-line agent in dementia with behavioral disturbance. We try all kinds of things first. SSRIs show first-line agents. A lot of patients, I'm suspicious that a lot of patients have depression. They are just not capable of communicating that depression in the same way with their dementia that other adults are. There may be some other mechanism of action, but that and environmental change are a lot of what we try as first-line agents. If you go to the geropsych unit at Northwestern, talk to the geriatric psychiatrist, you will see some patients. Now, that is a pretty profoundly impaired outlier group amongst patients with dementia. So, but for that, kind of a review of that literature in its entirety, we need another grand rounds, given ideally by someone who's boarded in geriatric psychiatry. So it's true you do see it. And most often I see Seroquel used, although even the data of choosing that one over other things, or is that just the one that's been around the longest? And so once you try something and you see it work once, you stick with it for the rest of your career. It's not entirely clear. Some of that is because Seroquel has a very low D2 blockade that I mentioned. And the older you get, the more likely you are to get Parkinsonian side effects from strong D2 agonists. But I don't know if the choice of quetiapine is even that rational. Like if we're really thinking about it in that regard. But that's a different topic about it. But it's definitely not something that should be thrown around lightly for patients with dementia, or even older patients, even just geriatric patients who don't have dementia, have higher rates of all-cause mortality on antipsychotics.
Thanks. There was a question that came in about whether there are non-pharmacologic management strategies that work for people with bipolar illness.
Oh, yeah, well, that's true. Yes. Cognitive behavioral therapy works for depression. And there's data on using it in bipolar depression too. And there are some patients who certainly augment their mood stabilizers with that. Maybe there's a rare patient who, if their hypomanias are infrequent enough and not destructive enough, who finds that's effective as monotherapy. I more often see that major depressive disorder than bipolar depression, to be fair. But and other things too. So lots of things have been studied. Sunlight doesn't seem to cause mania if you give it at normal hours, just like for a major depressive disorder. Exercise has all kinds of data for all kinds of depression. So I wanted to update you on the medication piece because I felt like that answer has changed from your step 2 of the boards, which maybe in the last time you got a psychopharmacology didactic. But there's certainly more than just medication for bipolar depression. Yeah.
Awesome, thanks. And then there was some general appreciation for commenting on the stigma attached to antipsychotics. And then maybe we'll move. There were a couple questions that came in about the latter portion of your talk about the new facility.
Okay.
Namely, somebody wondering where the patients who used to be admitted to the UW psychiatric unit, I think here at Montlake, where those patients are now being triaged to.
Some go to the adult psych unit at Northwest, some go to Harborview, and some go to the voluntary psychiatry units in the area, Fairfax, Swedish, Navos, things like that. From a systems perspective, do we think about this? There's inpatient child psych at Seattle Children's. We have faculty there. The VA has an inpatient unit. There's adult psychiatry at Harborview. And then we're going to have geropsych and these kind of longer term civil commitments at Northwest. Hopefully, we'll be able to expand and staff a voluntary adult unit up at Northwest as well, within the remodeled space where geropsych is currently. That probably won't be until 2025 at the earliest. But it's hard to make one psych unit that's good for every kind of patient. It's like on medicine, sometimes you need an ICU. It's the same kind of thing. The treatments are different. Group therapy is different. And so the skill set of the physicians and the nurses are different. And so there's an advantage to having a kind of a number of different psych units that targeting different types of patient populations.
And that may relate to the last question that came in about that, which is when will the new psychiatry facility be opening and starting to admit patients?
Neuromodulation, the ECT and TMS, it'll include outpatient. That'll open up in late April or early May. The geropsych unit will move into the building in early July, and then I think the plan is to start admitting patients to the long-term care unit in the latter half of this July. You can't admit 75 patients all at once. That would be chaos. But it'll open in stages over time.
Awesome. Well, I think we hit at least all the major questions that came in, and that was a great presentation. Thank you so much for sharing both parts of that with us. I think both interesting and highly relevant to our audience here. And thanks everyone for attending today. It's been great to have everybody here. We'll look forward to seeing everybody back in 2 weeks.
Thanks.